Yeah, we chose that title largely because of the amount of debate that was being stimulated by the suggestions that cardiothoracic consultants should be present in the trauma centres within 30 minutes of call. So let's just consider why the need, first of all. Here's some very brief quotes from the head of the National Audit Office back in 2010. Current services for people who suffer major trauma are not good enough. There's unacceptable variation. That means if you're unlucky enough to have an accident at night or at the weekend, in many areas you're likely to receive worse quality of care and are more likely to die. We must get a grip on it, we must move forward, we must prevent unnecessary deaths. Of course, we all know that chest trauma is a significant cause of avoidable death and morbidity. It's a cause of death in 25% and an associated cause in another 25%. It's predominantly young adults. Outcomes are directly related to the environment and equipment and particularly the expertise available to deal with those chest injuries. And it is timely care. There is an issue as to how soon and how quickly that care is provided, both immediately, in the acute phase of illness, and actually continuing expertise into the recovery phase. But it's not just the classic trauma that we have perhaps got used to, but let's also consider the various extreme threats we're faced with. The improvised explosive devices, vehicles or static. The person-borne devices, the 7.7. A lot of people forget about 21.7. They were the same bombs. They'd been made at the same time. The chemicals had degraded, and hence it didn't work. Madrid, Israel, Iraq. Our active shooter events, Cumbria, Hungerford, Dunblane. There's plenty more I could have listed. There wouldn't have been enough space to actually list them all. They are incredibly common. And they've happened in places we would never expect them to happen. Utoya is a classical example of that. And then the marauding terrorist attack using firearms and explosives, the Mumbai-style attack. And Mumbai is not the only example. A lot of the information currently around the planning and the intelligence around the marauding terrorist firearms attack is restricted, but this is a statement that is available, could generate a significant number of casualties with life-threatening injuries that require immediate medical intervention to prevent death. Reminder, Mumbai was, as I remember correctly, 166 deaths and 300 injuries. If we look at Madrid, 191 deaths, 1,800 injuries. We look at Utoya in Norway, it was roughly 74, I think it was, deaths, but another 100 injuries, of which 60 were predominantly serious or critical injuries involving most of the torso, some head injuries. And with our major incident planning having to take account of mass casualties, is your trauma centre ready for 100 to 200 P1, perhaps P2 casualties, and level of injuries that will overwhelm your local organisations? If you look at some of your major incident plans, you might find, if you look at them, a lot of people haven't read them, that some of them state there will be a 1 hour operating time for a casualty going through your operating theatre, including anaesthetic and operations, because you're going to have so many following, you can't take longer. Are you ready for it? And on that, I'll ask, first of all, Jim O'Connor to come and speak, tell us how trauma networks have been set up in USA, followed by Keith Porter. Jim?
Good afternoon, everyone. So this is the die-hard group, staying till the bitter end. I appreciate that. So I am a cardiothoracic surgeon. I was in private practice, as we would say in the States, doing cardiac, thoracic, and vascular for about 15 years before I decided a change would be a good idea, do something really easy. So now I work at a trauma center. My psychiatrist and I are still working on that. So how do we do it in the United States? I think there's a picture of someone that certainly this audience doesn't need to be introduced to. You can always count on Americans to do the right thing after they've tried everything else. And Sir Winston Churchill himself was a trauma victim, was struck by a car in New York City, crossing the street on Fifth Avenue, sustaining thoracic injury, multiple rib fractures. And that's where I work now. This is our, I don't know if that's working, that's our new building. Brand new, just opened. It's a building just for trauma. This is our old building to the back, which we're renovating. This is physically attached to the University of Maryland, and we all hold faculty appointments at the university, but this building is designed just for shock trauma. That's what we do. And I think every place needs a motto. This isn't the one that we actually use, but it's the one I think we should use, which is idiocy never underestimate the power of stupid people in large groups, which sometimes defines our faculty. Not necessarily our patients, but certainly my partners at times. I've also had the privilege and experience to set up a trauma center. This was a 435-bed hospital in North Carolina, which in 2 years we took them to be a trauma center. We had a cardiothoracic service, neurosurgery, fairly good intensive care unit group, so a fairly robust amount of resources, and that's my team right there. No sexist jokes, but 4 blonde women, what could possibly have gone wrong? But what a fabulous group and what a great opportunity. So I kind of come at this at two different ways of looking at it. One is kind of from the 30,000-foot look at, and the other is really granular in getting it done. So the trauma systems in the United States evolved over multiple years and decades, and really the principles are extraordinarily simple, but not always easy to implement and carry out. We talk about the golden hour, and we'll talk about that a little more. Bringing the appropriate resources to the patient, the first responder at the field, as opposed to just going, picking up a patient, or having the family drive you in and drop you off in the emergency department. The interventions that can be done in the field. Bring then the patient to the appropriate resources, not just to a hospital, but to a hospital that's going to be able to take care of whatever that injury set that you have. And we keep talking about the right patient to the right hospital at the right time. And I think the caveat in that is that not every hospital has to do everything. You don't have to be all things to all people, but you really, whatever you're going to choose to do, you have to do it well. So your hospital may say, we don't really want to take care of complex pelvic fractures, bad acetabular fractures. That's fine. But those fractures which you decide you're going to take care of, then those have to be handled well, and then have the ability to transfer those patients with more severe injuries someplace else. So, you kind of talk about ambulance services. Larray, I guess talking to this audience, he was clearly on the wrong side of the conflict, but a great concept in terms of ambulances. He also was the gentleman who figured out triage. He was also credited with doing the first pericardiocentesis. I don't know if that's really true. I'm old, but even I wasn't around for him. The lessons we've learned from the military are huge, and especially in the latter half of the 20th century in the United States, between the conflict, the war in Korea and the conflict in Vietnam, in terms of being able to get casualties to definitive care relatively quickly. In the Korean War, it was 85 minutes, and it was the first use of helicopters. Certainly anybody who's ever seen reruns of MASH, that's the iconic picture, is the helicopter coming in. And same in Vietnam, where the time from injury to definitive care was a matter of 27 minutes from the time that the casualty was picked up. And clearly we did other things well. Maybe not well, but we did them better in terms of volume resuscitation, better organized forward teams. And that's obviously impacted the mortality in a very positive way. It took us in the United States till 1966 to actually figure out that trauma was a disease. And this was the landmark paper that woke up a lot of people. Accidental death and disability, the neglected disease, underlined, of modern society. Where we really, in this paper, said this is a disease that kills, it's the major killer in the first 4 decades of your life. It remains a major killer as you grow older, usually in the top 5. And we're not doing anything about it. Dr. Cowley, who the center where I work is named after, and he was the founder, was a co-author of that paper. And obviously this grew out of our experience in certainly the Second World War, and more definitely in Korea and Vietnam. And this was a quote right out of the paper: if seriously wounded, the chances of survival would be better in the zone of combat than on the average city street. So if you were going to get shot, you were better at that time to get shot in Da Nang than in Baltimore. The American College of Surgeons looked at that. It took them another 10 years, an entire decade, to kind of think through this. And they came up with through their Committee on Trauma, the resources for the optimal care of the injured patient. This says, how do we really design trauma centers? Now they finally realize there's a need. How do we set this up? And what they said was, trauma is its own specialty. It cuts across numerous specialty groups, but the fundamental concept of taking care of a trauma patient needs to be centralized. There should be very strict criteria for trauma center designation, and there should be tiered levels of care. Again, not every hospital has to do everything, but what you're going to do it well. And we should regionalize trauma care. So the way we did this, I wasn't there for this either, but the level 1 center in the United States is generally a university hospital. It's really tertiary and most often quaternary care. There's an in-house trauma-trained surgeon taking that first call. And it also has the additional mandate of education of our residents and fellows, and sometimes junior faculty, the research component to drive this, as well as prevention and engaging the community. That's what is expected of a level 1. That's the highest tier of the American college. A level 2 center generally is a non-teaching hospital, fairly big hospital. It may have occasionally will have a freestanding residency program, but not always. They usually do have subspecialty care, but it's usually not a tertiary care facility. It has some subspecialty care. And level 3 is really, I guess, akin to what your district general hospital would be. It can care for most injuries, but it doesn't have the same robust amount of support in the subspecialty care. And that's how they are tiered in the United States. The other difference between the level 1 and level 2 is obviously the research, education, and outreach component is not as important. The level 1 centers kind of anchor this entire system. So, what were the advantages of setting this up? Well, obviously, defining what a trauma center should be and say, yes, if you're in Montana and you want to be a level 1 trauma center, that's the same as if you're in New York. They talk differently in New York. They talk like that over there. But I won't bore you with how I grew up talking, all right? Because otherwise people wouldn't take you seriously, you know what I mean? So, but they said if you're going to set up a trauma center, it doesn't matter where it is in the United States, you're going to have to meet these criteria. We really are going to stick to this idea of tiered levels of care, and we really are serious about regionalization. We don't need 3 level 1 trauma centers sitting next to each other, although there are cities that have that. And that's what I consider in the next part here about unhealthy competition. And it has shown to improve outcome. The disadvantages are there are underserved areas, and those areas tend to be the more rural areas where the transport time to definitive care, especially to a level 1 center, can be kind of protracted. There definitely is unhealthy competition. I'll tell you a little bit about Baltimore, where I am. We don't really have that, but there are cities where there are 3 or 4 level 1 trauma centers in major urban areas, which is simply insane. But sometimes this is economically driven, not patient care driven. And certainly there are economic and government factors that are coming into play. We're just now trying to figure out what our new healthcare law actually means. And if from the government, if you think the problems we create are bad, just wait till you see our solutions. We don't really know what these solutions, proposed solutions, and I'll put that in quotation marks, are going to be. We really don't. We've got a big law that's been passed, but we still don't know how that's going to be implemented, how that's going to impact what we do, other than it's going to be different. So the evidence, at least in the States, for mature trauma centers would say the following. Trauma centers versus non-trauma centers, you have improved survival and improved outcome. Outcomes such as return to neurologic function, return to work, any of the metrics you want to look at. And even if you look at level 1 versus level 2 centers, survival is better in a level 1, all else being equal, in terms of ISS and depth of shock and all of that. And improved outcomes, especially in the neurologic arena. Again, it defines the standard of care, And the other thing where I think this is really useful is that because you're in a trauma center, you're now interacting with your first responders, your ambulance service, and EMS providers. You are now in some ways helping drive their protocols. What do they do in the field when they arrive? What are they allowed to do? What's their scope of practice? How do you help educate those folks? So that not only are we sitting in the ED waiting for those patients to come in, but we've actually outreached to our partners who do the field care and help influence what they can do. Again, the designation and verification criteria. And the other thing is this whole idea of vertical and horizontal integration. When I was in North Carolina, I went through 3 CEOs in 2 years. The joke was, who's running the hospital today? One of the CEOs, who obviously was not the brightest bulb in the chandelier, said to me, so as a trauma surgeon, you spend all your time in the emergency department. Yeah, no, because he just, quote, didn't get it. So when we talk about this integration of care, it really starts with our field providers and EMS, and then it comes to the hospital, and these are all the folks that are going to touch a trauma patient. And that's not everybody. Your subspecialists, your ED physicians, trauma surgeons, your anesthesia team, ICU, et cetera. And then I tell you where I think, at least where I work, where we don't do a particularly good job, the sicker you are, I think, the better we are. We kind of fall down on the rehab piece, which is essential. And it requires, you know, it's not as dramatic. You know, people coming in, opening chests and doing all this, that's kind of dramatic. You know, this is the real work, though, with our physical therapist, our occupational therapist, and our case managers are the people who actually can figure out that that patient with that set of injuries and insurance, which is just a total nightmare trying to figure that out, what hospital they can go to for their rehab. So I think that's really important. So that's kind of the 30,000-foot view of American trauma centers. I'd like to kind of talk a little bit about Maryland because it really is a unique situation, and I think in some ways more easily to get your head around how you set this up. So this is Maryland, sits on the eastern coast, as you know. New York is up here, where I was born and raised and kicked out of, and Washington, D.C. is right here. The majority of the population is in the area between Baltimore and D.C. The western part of the state is rural and agricultural. The eastern shore is fairly rural, and over here is an area which is kind of the resort area. Ocean City is Brighton, but people who can't speak English, okay? So that's what's over here. Majority of the population right in this corridor. Population's about 5.8 million, give or take. There's not much it's known for except our national anthem, which was the Star Spangled Banner, War of 1812. I hope there's no hard feelings about that. And this is Fort McHenry, sits out in the bay. It's the site of a prior U.S.-British disagreement. Thank heavens that's all resolved. And that's one of our state helicopters. I'll talk about our helicopter transport. So the guy who really drove this was R. Adams Cowley, and I'll talk to you a little bit about him because you talk about fascinating, interesting people. He took the same principles, the golden hour, bringing the resources to the patient, bringing the patient to the appropriate resources, right hospital, right patient, right time. But guess what? Implementation was not at all simple. This was a decades-long struggle to get us where we are. And he's really the guy that coined this. I don't know if he coined it or if he was a book written about him. I think one of the newspaper people from the Boston Sun actually, I don't know if he created it or put those words in his mouth, but the golden hour between life and death. If you're critically injured, you have less than 60 minutes to survive. What he went on to say is you might not die right then. You might die 2 weeks or 2 days or 2 weeks later, but whatever happened in those first 60 minutes that we couldn't fix is really what leads you to go on to die. He had a tremendous interest in shock very early on. And he said, think of it as shock is defined as the pause in the act of dying. And there's plenty of data to suggest this, because what happens with trauma? If you have a head injury, you may be dead. A traumatic, a terrible, devastating head injury or spinal cord injury, you're probably dead at the scene. You rupture your aorta, you're dead at the scene. What kills you early is hemorrhage. So the sooner you get to definitive care, for airway control and control of your hemorrhage, the better your chance of survival. So he had this real interest in shock. So the first clinical shock unit was exactly 2 beds. He convinced the university to give him 2 beds to study shock. In 1968, can you get this? He actually convinced the military to give him a helicopter to transport patients. Could you imagine going to your Defense Department or our Defense Department now? They'd lock you up. You know, they would have, you'd be seeing a psychiatrist and a bunch of people from the CIA wondering why you want a military helicopter. In 1969, he had a 32-bed center, and 1989 was that old building that you saw in the background. So that's how long it took, almost 30 years, for him to start getting these people thinking about how to take care of it. It really is R with no period, and the story behind that is the family name. His mother's maiden name is Adams, and the family name that they were going to use for his first name, his Christian name, was Rufus. And his mother couldn't come to write Rufus on the birth certificate. She wrote R and stopped. It's not even a period, which has driven people crazy for years. He was a military surgeon towards the end of World War II. He did not see active combat, but did take care of the casualties in the the tail end of 45 into 47. His interest was the fundamental question of shock. And this is the part I like. He was a cardiothoracic surgeon. When he wanted to start this, he was in the Department of Cardiothoracic Surgery. When he really wanted to bring this whole idea of a trauma center forward, his colleagues in the cardiothoracic department and the Department of Surgery at the university thought he was absolutely stark raving mad. So he went outside of the system to the political end. He had a tremendous passion for this. He was politically skillful, and he had one stroke of luck, which was the governor's senior aide was injured in a car crash, terribly injured, multi-trauma, wound up at a small hospital. The governor called him and said, "Can you take care of him?" He said, "Certainly, give me a police helicopter." Went. The story is, whether it's true or not, they wheeled in, grabbed the patient, and said, "We're going." They said, "Do you have any transfer orders?" He said, "Yeah, it's the helicopter." Took the patient, brought him to shock trauma. After that, guy, thank heavens, did very well. The governor then became his best friend. So he's very politically connected. And what's unique about our system, and I say ours in terms of Maryland, we're the most integrated trauma system in the country. The other states don't have this. And it was really him that pushed this. So this is a really fully integrated and mature system. And within the state, the Shock Trauma Center actually, we're mandated by the state of Maryland to actually have criteria which exceed that of a level 1. Okay, so we're verified by the American College of Surgeons as a level 1, but the state says you need even more than that. And in the city, we also have Johns Hopkins, which is a level 1. They do all the pediatric trauma, and they're the burn center. So even though there are 2 centers in the city, we've decided that's what they should do, and this is what we should do. And then there are other centers around the state. We have a great ground transport. Our EMS is mostly paramedic EMS run by our fire service. And then there are multiple jurisdictions that have either volunteer or professional first responders. Our air assets are through the Maryland State Police. So these are state police officers who are paramedics. So the first time you see them wheel a patient from the heliport down, you know, they're all in their flight garb and everything, and they got their kit, and they also have a sidearm. It's a little disquieting. And then we have a very sophisticated, integrated communication system. So I want to talk about each of these individually very briefly. Again, here's the state. Baltimore's here, Washington's here. There's a cluster of hospitals here, obviously, our hospital as well as Hopkins. And you can see that the trauma centers are reasonably well distributed around the state, with the exception of over here on the Eastern Shore. We don't really have anything. But these little dots, not the red ones, but the other ones, are where the state police helicopters are. So we have 8 helicopters around the state that can go pick up patients. Baltimore has, again, in the city, we have our EMS paramedics. That's run through the Baltimore Fire Department. These are the multiple jurisdictions that you see. That sits outside our trauma resus area. from the volunteer jurisdictions that we use. And also, first responders are essential. The ability for those folks to go out and do the right thing at the field is huge, and we take helping them and educating and partnering with them as a very serious piece of what we do for a living. Our air transport is all through state law enforcement. So again, Maryland State Police are the only ones who run the helicopters for us. There are flight paramedics, so all these guys and gals have gone through the academy. They've all been out doing real law enforcement before they can be paramedics. They go through paramedic training, flight training, fairly seriously well-trained bunch of guys and gals. Very impressive skill set. They are trained to do RSI. The way they keep those skills up is that every couple of months they'll rotate through our operating room under the supervision of our anesthesia team so that they can keep their skills up. And we also have a combined mortality and morbidity. Any case reviews will come through us. The other thing that's really interesting is since these helicopters are stationed around the different parts of the state, the flying time is not that they have to go out from Baltimore 43 minutes to the western part of the state and 43 minutes back. There's a helicopter out here. So from the time that they get called, it's a short jump to the scene and then rapid transport to us. And they do have night flight capability. So we're pretty fortunate to have that system. It's very well integrated. So how does this all get integrated? And it's the communications piece. And we call it SysCom. It's our systems communication. It's ground and air. This is the SysCom area, which is literally a block from the trauma center. It's not designed to handle 911 or 999 calls. This is field provider talking to hospital, field provider talking to trauma doctor. This is Tom Scalea, who's a good friend and runs the trauma center. He's a physician in chief. Of any field provider, volunteer provider out on the western part of the state can pick up, call SysCom, and get patched in to a trauma attending. They carry the brick with them. And that conversation can go on. You're getting the information from the field provider, and maybe that patient's airway, maybe you need to go to the nearest hospital so that their airway is secured. Maybe that's a patient who needs to fly versus ground transport. That's an ongoing, contemporaneous conversation. It's fantastic. The other thing is that in this communications center, there is a desk for the Maryland State Police duty officer who is in charge of all of the air assets. And he or she can dispatch 1, 2, however many helicopters they need to take care of the injuries at the scene. The center where I work is really the highest tier in the state. We have 24-hour in-house coverage. We have fellowship-trained trauma surgeons, but we're a trauma hospital. Our anesthesia team only works with us. They don't go to the university to do, whatever case they want to do at the university. They are with us. Trauma orthopedics, extremely well trained. They're not going over to do elective cases at the U. We have trauma radiology. We have about 5 of them who handle all of the trauma radiology as well as the ED. Same thing for neurosurgery. So we have a lot of punch, mostly because this is what we do for a living. You don't want to show up in our hospital, in labor, and you sure don't want to show up having crushing chest pain, okay? Because, we'd be sending you over to a CAT scan or something. So again, this is the place. We're a freestanding hospital. We're affiliated with the University of Maryland, but that entire building is designed to take care of shock and trauma. That's what we do for a living. We see about 8,000 patients a year. Of those, about 2,400 are transferred in from other hospitals. About 21% come by air. So that's a large number of people that are coming in by air transport. And that's kind of the statistic. We got a whole bunch of ICU beds. We have some specialty units. We have a neurotrauma unit, a multi-trauma unit. We have a critical care receiving unit for transfers coming from other hospitals. We have 13 trauma bays, but we can take care of 26 patients because the 2 people in the trauma bay will get to know each other very well. They're good-sized bays, but still it's a little interesting. And we have 10 dedicated ORs, one of which is a hybrid OR for our vascular cases. The TRU is our resuscitation unit, so when you show up, you don't go to the ED, you come to us. That's our resuscitation unit. That's where our trauma bays are. The TRU, our CAT scanner, As I said the other day, ABCs at shock trauma are airway, breathing, CAT scan, angio suite, operating room, all on the same floor. You wheel out of the resuscitation unit, literally from here through those doors in the back of the auditorium, and you're in the operating room. It's very complex, very compact, which makes our life very easy. So why does this work? We have really good community support. And the reason is, and funding. When you go to register your car in Maryland, a couple of dollars from your registration goes to a fund. If you're hurt in a road traffic accident and the helicopter shows up to pick you up, you don't get a bill for that. They just pick you up and take you. You don't get a bill from the state saying, oh, by the way, you owe us $15,000 because we just transported you. So the community realizes that resource that they have. We have enormous political support that we have to foster all the time because dollars are short. And I think the other thing is we have one mission. That's all we're there to do. But I would say that's translatable. In your individual hospitals, you can still have the mission of taking care of trauma patients. It doesn't have to be a separate building. It's just the mindset. It's the mission. That's what we're going to do. We also have some dedicated people. Agreed, they're a little bit off to do this for a living. We do wear pink scrubs. There's two stories about the pink scrubs. One was that Callie didn't want anybody to swipe the scrubs from his hospital. And the other was that it was the cheapest that he could get a hold of in terms of colors. I don't know which one. Either one sounds pretty good. But again, we have these people who this is what they want to do, and they're very trauma focused. Excellent question. Clean the slate. It's 2013. Could we do this now? And the answer is no. We don't think so. We couldn't recreate the system right now as it's currently configured. It's too costly, there's probably not political will, and there's too many competing interests. Back then, nobody wanted to take care of trauma patients. Callie was the guy. Just to dovetail into what was said at the previous session, work hour restrictions. How are we training the next generation of kids? And the older I get, the younger you all get in terms of trainees. How do we train them? I trained in an era where everything was an open case. I trained when there were no work hour restrictions. You left when it was kind of done. That was the way we trained, both in general surgery and in cardiac. And work hour restrictions, you know, it's hard work. You know, hard work never killed anybody, but it is illegal in some places. So it is hard work. Again, the former speaker who was here in the last session saying, you know, when they were talking to their trainees saying, well, it's a lot of work when I have to go home and do this. Yeah, it is. Guess what? That's what it takes. The other challenge is that the generation of residents that I'm seeing, they're incredibly facile with the laparoscope. I mean, I can't do anything with a laparoscope other than, thoracoscopic stuff I can. I did general surgery in a previous life. I don't do that anymore. I wouldn't know what to do with a laparoscope other than hit somebody over the head to get me the real instruments to open. I wouldn't know how to work. But that's the way it's going. We graduate about 1,000 general surgeons a year. Anywhere from half to 2/3 go into a subspecialty. So the specialty of general surgery, where that person would go do a thyroid on Monday and a fempop on Tuesday, those people are gone, at least in the younger generations. And very few people really want to pursue a trauma career. And a lot of the trauma is non-operative, interventional based. So we have a lot of pressures on how we train the next generation. The injuries that we actually have to operate on are pretty sophisticated, sometimes require sophisticated judgment, which is usually where you drop the ball, and sometimes some difficult operative stuff. You want to take care of a bad liver injury, you had best feel pretty comfortable rolling around and taking down a liver and, you know, figuring out how you can fix a hepatic vein or retrohepatic cava. If you haven't done a bunch, the first couple you do are really very unpleasant, especially if there's no one there to help you. If you're trying to do that by yourself, it's a very unpleasant experience. So, you know, we're going to have trauma surgeons that will or will not have that skill set. And my guess is that not every trauma surgeon will, and this is my plea. And my plea is to people in the cardiothoracic world, in specifically, and in general to those people in the subspecialties, that we have to get more involved in the care of these patients. We're not going to have the trauma-trained surgeon that he or she is really got all of that information and able to kind of think through the difficult decisions if it's a neurosurgical patient, if it's a thoracic case, vascular case, that those of us in these subspecialties will have to step up. So lastly, what do you need to do? You need organizations like this and others to drive the agenda, and you need champions. And that's us again. You need to go and kind of really talk about it all the time, sometimes to the point that people don't want to listen. There's also a great quote from Sir Winston Churchill that a fanatic is one who won't change the subject and can't change his mind. But you have to continue to bring that agenda to the folks that can do something about it. And sadly, those are the policymakers and the politicians, not a group that we usually want to sit down and have a conversation with. But they're the ones that really make the policy. When you do that, you do it in two ways. One is data-driven. Here's the data. And the other is the stories. Those stories of this child, this person, who got to the trauma center, and this is what we did for them. So tug at their heartstrings a little bit. It's really okay. And I think the biggest thing is overcoming the tradition of the way, well, that's always the way we've done it, and the kind of the prevailing culture within the hospital and within the medical profession. Community support's essential. Again, in Maryland, we're fortunate people are very happy to support the system, even though it's costing them a couple of bucks when they register their cars, because they know if they're injured, the system's there for them. The other thing we need is patience, which is clearly not a surgical virtue, okay? Let's face it, we like immediate gratification. People who do trauma surgery, immediate gratification isn't fast enough. So we even want it quicker. We want it fixed tomorrow, yesterday. It's not going to happen. It's years and decades. And you really have to engage everybody who's got a seat at the table. And I hate that expression of stakeholders. It always reminds me to see somebody standing there with a piece of meat that they're going to throw on the barbecue. But I think surgeons have to drive this, and that is no slight to the other specialties in our A&E colleagues. We really have to drive this because we're ultimately the ones to take care of them. And the other thing is you don't have to reinvent the wheel. You can kind of see what other trauma centers have done and pick and choose what makes sense for that particular region, to regionalize it. And I think that Maryland is a pretty good example because we're not a big state. So, 5,000, 6,000 people, that's kind of a fairly compact group. And finally, it's always about the patient. Every time you have these discussions with folks, it's always about the patient. It's not about you, your hospital, your training, your nothing. It's about the patient. And if you make it about the patient, you'll get people to listen. There's nothing more difficult to carry out, nor more doubtful of success, nor more dangerous to handle than to initiate a new order of things. Thank you so much for the privilege of being able to share with you a little bit of what we've done in the States. Thank you so much.
Keith?
Right, Chairman, ladies and gentlemen, thank you very much indeed for the opportunity of being here to speak today. And once again, a great pleasure listening to Jim and what goes on in the States. What I'm going to tell you, if you like, is something that's happened really, 15, 20, 30, 40 years after what's gone on in the States. Though I would just begin with my opening slide there on the left-hand side, Birmingham Accident Hospital and Rehabilitation Center, 1941 to 1983. It very much had rehabilitation up front, and it was the only and first standalone trauma hospital in the UK. Your patient came out of an ambulance direct into intensive care, and next door was the operating theatre. Highly successful hospital, closed by politicians for many reasons. 1993. So let me perhaps look at a little bit about the history of trauma care in the UK, because on the whole, it's a lag behind, and there was under provision of services. Interestingly enough, Osmond Clarke did a review in 1961 to try and give a way forward. It came up with exactly the same model as we subsequently have now of local hospitals, of trauma units, and then of major trauma centers. And if you like, level 1, level 2, level 3 hospitals as in the USA. One of the drivers for change in this country was a presentation delivered in the UK at the College of Surgeons by Donald Trunke in 1985, following on to the seminal work that he'd done on the development of regional trauma networks and systems in the US. That followed in 1988 here by the Royal College of Surgeons review of 1,000 trauma deaths, where it suggested that up to a third of those patients who died unnecessarily. And it advocated, therefore, amongst other things, getting the right patient to the right hospital in the right time. As a consequence of that, we introduced ATLS in the UK. Our paramedics learned additional skills such as infusion, such as intubation, and there was some improvement in trauma practice until about 2003, but it was marginal. Same time, we did introduce data collection, which highlighted many of the problems in relation to our patients, whether it be in pre-hospital care or in hospital care. And it does need a political will to get any change, as Jim said, in the States. And the same thing happened here. And there were 3 important reports. Trauma Who Cares, National Confidential Patient Inquiry, looking at outcomes and deaths, had some very hard and fast statistics. And it showed that only 17 hospitals in the UK had all on-site clinical services, so neurosurgery with cardiothoracics, general surgery, TNO, etc. This was a review over a 3-month period in 2006, where all patients with an IS over 15 were reviewed, and there were 186 hospitals in this study, 796 patients. And for those patients, only 47% or just over received a good standard of care. Where you had high volume centers, then patients did better. And in some of these hospitals, they didn't see any major trauma actually within the trial period. It also showed the problems at the front door, 13.4% inappropriate initial hospital response. And of those, if you're treated by the most junior doctor, as you'd expect, your error rate, major error rate, was approaching 24% compared to a 3% error rate if you're managed by the consultant. 1 in 5 hospitals didn't have a trauma team at that time. Only 9 hospitals in the UK had a major transfusion protocol. And if you arrived alive to a hospital, then you were 40% more likely to die compared to if you arrived in a major trauma center in the US. Another important report following on from this is the National Audit Office report of 2010, where it showed of those patients who actually needed to transfer between hospitals, only 36% of patients actually were transferred for specialist care. A major selling point for this is actually head injuries, and with a key target of getting patients onto an operating table in the care of a neurosurgeon within 4 hours, then within the study of NC-POD, only 20% of patients were involved. And the death ratios, if you're actually in a non-neurosurgical or neuroscience center, was very significantly worse unless you're actually in a neuroscience center. Following on from the previous report, we had the government next stage review in 2008. It was now beginning to get the message. Critical care, or critical of quality, of service provided to our trauma patients, that there should be a high quality of care for all, no geographical bias, like being in London and the London trauma setup. And it did actually begin to advocate the development of major trauma networks. Finally, we got political buy-in, and unless you have that political will, motivation and support, you go nowhere. And Lord Darcy said this, reporting in the House of Lords, then fully endorsed by Ben Bradshaw in the House of Commons. So they've taken on board all the critical aspects of the NC-POD report, and this was looking at the totality of care, not just pre-hospital care, but the surgical sciences right the way through to rehabilitation. The premise on moving this forward was very much that there was unquestionable evidence that by setting up trauma systems in England, then we could reduce our mortality by 15 to 20%, and this would equate to 450 to 600 lives in England per year that are saved. So moving forward, the recommendations were that there should be the development of trauma networks and trauma systems driven by collaborative discussion between ambulance services and primary care trusts. Quite often, the networks actually mirroring the ambulance service geographical network, that a return to TARN, Trauma Audit Research Network, to facilitate robust audit would be mandatory, and there needed to be very clear inter-hospital transfer policies. A national clinical director was put in place, Keith Willett here, to drive this agenda. And he drove that very hard and very successfully. And in fact, his arguments were very much about equality of access for everyone, treatment for everyone, optimal trauma management, irrespective of geography, primary triage to the right place, again reiterating right patient, right hospital, right time, and to expedite inter-hospital transfers. So a UK major trauma centre is defined as a specialist hospital where all of the specialties are on site. It should ideally see 400 major traumas a year, and it should serve at least a population of 2 to 3 million. And over 5 years, the evolution set up a consolidating time of a major trauma system, which would anticipate to see 15 to 20% increased in lives saved within that particular system and network over a first five-year period. Our major trauma centres have to have all the surgical specialties and support on site. They support the trauma units, they support pre-hospital care, they have robust rehabilitation and repatriation arrangements in place, and of course support a governance structure, and as Jim has said, having also as within their armamentarium research, education and injury prevention. Integral to this is consultant availability, and for the key specialties, general surgery, cardiothoracic surgery, neurosurgery, trauma and orthopedic surgery, anesthesiology, there should be a consultant available within 30 minutes, but a senior trainee immediately available. And in the case of cardiothoracics, in this august environment where I am today, that senior trainee must have the ability to deliver a resuscitative thoracotomy capability. I'd have to say, actually, when talking about resuscitative thoracotomy, I'm well aware of the outcome results, but resuscitative thoracotomy, in my mind, is only a small component of the service that cardiothoracic surgeons bring to the totality of the care of the patient, whether it's to do with my patients with pulmonary contusion, issues with chest drains. It's made a remarkable difference in Birmingham by actually being on a single site and having our cardiothoracic surgeons much more available. Talking specifically about Birmingham, this is our trauma network. There are actually 3 adult major trauma centres in the region, Stoke, Coventry and QE at Birmingham, 1 children's hospital which covers the whole region. The small TUs, trauma units, are those in the purpley colour, and there are a number of hospitals that don't play at all but just functions as with minor injuries units. Our patients are triaged based on the modification of the American College of Surgeons field triage tool, and there are 4 components to this. The first 2 being the most critical, which are the vital signs measured and the assessment of the anatomy of injury. And if you tick on parts 1 and 2, or stage 1 and 2 in this triage tool, you're mandated to go to the major trauma centre. If you tick on 3 and 4, mechanism of injury, number 4 being specialist circumstances, like, for example, you're a haemophiliac and you're now traumatised, or you're pregnant and you're traumatised, then discussion between the ambulance service and the trauma centre will decide what is the best option for that particular patient. So what's happened, what changes have occurred in the UK, or actually in England, since the 1st of April last year? Our ambulance service now have trauma desks, and that means there's a senior clinician available 24/7 to identify major trauma and then to ideally ensure that that patient gets to the major trauma centre. If it requires to go into a DGH, a trauma unit in new language, for airway stabilization, then they will coordinate the onward transfer of that patient to the major trauma center. Equally, there's now a medical team available in my region, a major emergency response team, very similar to the military MERT capability. So we can get a consultant-level clinician supported by a paramedic to the scene of an incident within the West Midlands 24/7 in the daytime using a helicopter platform, at the nighttime using a car. So we have this enhanced care team. It may get to the scene, it may RV, rendezvous, with an ambulance on the way to the major trauma center. And we accept 45-minute travelling times, and in relation to my own region, that includes the whole of the region within our network, with the exception of Hereford and south of Worcester. And it's also put together within the setup a robust transfer arrangements from TUs to MTC, and the clinician in the car or on the helicopter has the capability of moving that patient from the ED, ventilated or otherwise, to the major trauma center. When you move in the ED, then our patients have a standard handover, standard terminology throughout the region, enhanced ED cover, and now 24/7 ED presence in the department. I mean, the US have had it for some time. The military do it at all levels of care. We now have it in our 22 major trauma centers in the UK. So you are received by an ED consultant. There is a senior nurse amongst others available, and there is an escalation policy to deal with multi-casualties, whether it's 2 or 3 or tens or hundreds for each department. In relation to my own hospital, it's meant minimal changes within imaging. We already had a 24-hour-day MRI and CT capability, but we now have to deliver CT within 30 minutes, though we actually now have a straight-to-CT policy where many of our patients coming in on the air ambulance with a clinician accompanying that patient, these patients all go direct to CT and then back to resus, or from CT direct to theatre or to interventional radiology. We now have an MRI capability within an hour. In relation to theatres, again, it hasn't required much change where I work, but every major trauma centre has to guarantee an available theatre 24/7 for major trauma. It's meant ramping up on-call capability and really creating more time because of the increased throughput of patients, not just the true major traumas, but those with ISS 9 to 15, which are, in fact, the bulk of our work. In my particular hospital, it's meant a phased increase in beds on the projected increased numbers, and that's been on our trauma ward, which is, in fact, interfaces with our military ward, where our patients with more significant injuries are cohorted. And it's also meant a stepwise increase in our critical care capability, 2+2, and a further 2 to come. Very important, as Jim alluded to early on, is rehabilitation. All patients have to have a rehabilitation prescription done within 24 hours of arrival, and that sets in motion the onward discharge plan for the patient. So if they're out of region, it's in fact the discharge plan that allows the patient to go back to their host trauma unit for ongoing care and rehabilitation. Within our trust, we've appointed an acute rehab coordinator, an acute care rehab consultant. We've uplifted our AHPs, and we've established much more robust policies in relation to discharge and links with other services, including community services. And if I ring a trauma unit now, then the arrangement is they will take the patient back to them within 48 hours, or to our neurosurgical rehab capability called INRU, that's within 24 hours. Integral to all this is the coordination. Who looks after the polytrauma patients once they've got past ED? Who conducts the trauma orchestra? And there are various models of care in England for this. Sometimes it's actually the orthopaedic surgeons, some in George's, sometimes it's vascular surgeons at the London, sometimes it's intensive care, as in King's. In my own hospital, we use a hybrid sort of model where we have a consultant trauma clinician. These are committed individuals with a track record of a good history in managing trauma patients, and they come from a number of backgrounds. trauma nurse practitioners are 7 days a week, but not 24/7. Do all our coordination of all what goes on, whether it's patients for theatre, returns to theatre, patient discharge, or ensuring that all patients are monitored. We return to our returns to the Trauma Audit Research Network. That's getting increasingly important because we now have to return 25 days after the patient's discharge, and based on those returns, there is an enhanced payment back to the trust. So if we don't get our returns done, then we don't get what in fact is £3,000 per ISS over 15, or £1,500 for patients ISS 9 to 15. So clearly the coordination here driving our trauma audit program as well is integral to ensuring that we hopefully at least can not lose too much money within major trauma. We have to return to data, and every quarter you get a return of data. I won't go into the complexity of this, but essentially you need to be in the green, which we are on the parameters shown here. But as we have a direct CT policy, we actually score very well. But within my own specialty, the BOSE guidelines of getting a free flap done within 72 hours of injury is a big challenge if you're an orthopedist, and that actually we've been able to achieve. So, in fact, we have come a long way in the last year. In my own trust, our first anniversary is in fact on Tuesday, but it has been very painful, I can tell you, on a background of a flat economy, no additional monies, how to make this work. And I'd have to say that without exception, our subspecialties have actually risen to the challenge. It still isn't right in my trust. We are still very pressured for beds. We've got nearly 100 intensive care unit beds at the moment, and still we struggle to get our patients in, and particularly, for example, elective cardiothoracic work as well as elective neuro. We struggle, I think, at the moment to deliver some of the services, but it's always been said that a trauma system takes about 5 years to really bed in. So I think in 12 months we've come quite a long way. Our latest TARN data would suggest that in the first three quarters of the year, within the Birmingham, Black Country, Hereford and Worcester Trauma Network, we've seen 15 additional lives saved. So on the background of very little, if not nil, investment, but a lot of goodwill, we've already made a positive impact to patient outcome. Chairman, thank you.